Welcome, everyone, to this week's episode of the Essential Therapies Podcast with Dr. Cindy. In today's episode, we have Dr. Terry Gibbs, who is a seasoned OBGYN with over 40 years of experience specializing in perimenopause and menopause. And he has a really valuable and very insightful conversation with Dr. Cindy on the topic of hormone replacement therapy. So this is a great episode. If this is something that you have any interest at all in, then this is an episode you definitely want to listen to. So hope you enjoy this one, and we will see you again next week.
Thank you for joining the Essential Therapies Podcast. I'm Dr. Cindy Hodgson. I'm a physical therapist and exercise physiologist, coming to you from Essential Therapies in Toledo, Ohio. And the focus of my podcast is to give you options for essential therapies, and with a focus on fascia often, but not always. So I'm super excited today to bring a very wonderful guest, Dr. Terry Gibbs, who I've known for quite some time now. He is a...
She's my doctor.
What? He's now retired, but an OBGYN for nearly 40 years, specializing in menopause and premenopause health, but has also delivered many babies.
Lots of babies.
So, and we first became acquainted because he was my doctor. So,
and then she became mine.
so he has a good understanding of fascia from both sides now. And one of the things I really remember about when I came back to this area and came to see, I was having some discomfort, and it was new, and I was kind of scared about it because it was like, I wouldn't have been surprised if you would have told me I had some fibroids or a tumor there or whatever. And you did the ultrasound first and you were like, this is all scar tissue. Do you remember that? That was a long time ago. And so I was relieved, and you said, well, I would send you to you. So, go ahead and work at it. So that's a whole different story. But today I really want to talk about so you've recently retired and you've come into this education space. So to educate our followers about this whole topic of hormones. So as a women's health physical therapist, and I spent a lot of my time dealing with women's health issues, and for a while, which is like almost 20 years ago now, I was only doing women's health for a few years. And now it's not the main part of my practice, but I see it almost every day. And I get this question often: what should I do about hormones?
It's a wonderful question.
Yeah, and so then after the appointment I talked about where I was having that pain and it was adhesions and I took care of that, I came to you, I remember later, saying, I can't sleep. It was like, I'm sleeping for 15, 20 minutes at a time, and I wasn't having traditional symptoms of hot flashes during the day at all, and I was still menstruating even, but here I was, dying. And I remember you going into this whole story with me, and I was fearful because my mom had breast cancer, and it was something that I had heard, you stay away from that. I was always the girl who wanted to be Miss Natural, right? Of course, I ended up having C-section and all of that, but, I would love for you to explain how you handle all of that. And then you really calmed me back then, and you saved me. I mean, I remember 3 or 4 days into taking the bioidentical hormones you suggested for me, I started to sleep, instead of 20 minutes, it was 2 hours at a time. And within 2 weeks, I felt like a normal human again.
Yeah.
So I hear this a lot, not only the traditional, as we're aging, the vaginal dryness kind of a thing, but also fatigue and just things don't feel right, and a host of symptoms. So I am going to give you the floor.
Well, thanks, first of all, for letting me come and talk about this. And thanks for all you're doing for women's care. We really appreciate that. And then thanks for being my doctor. But, my journeys learning about hormones started back in 2002. I was younger at that day, at that point. And I was talking to a colleague who was old and wiser, and I was thinking about, what I wanted to do towards the end of my career. And I had all these thoughts, and what about this? And he looked at me and he said, menopause. I think I would do menopause because people just don't know about it. And oh, is that true? And so just after we had that conversation, there was a study that came out in July of that year, July 7th. I remember it because everybody was knocking down the doors and, the phone calls, because there was a study called the Women's Health Initiative, and it was the largest study to date. It was almost $1 billion study. It will never be redone. But we wanted to answer the question, can we give hormones to women to protect their hearts going into the menopause? Can we give it prophylactically for prevention? And the answer came back. They stopped it early because they found that there was more breast cancers reported than they expected, and heart attacks. And it was a 30-second soundbite on the news that night. Hey, estrogen bad, estrogen kills. And now for the sports, And so...
And this was in 2002.
This was in 2002. And so everybody just took a gasp. And then the next morning, it's like, what am I going to do? What am I going to do? So everybody's throwing the estrogen down the toilet. But within a week, as we could predict, everybody's calling miserable and saying, what do I do now? And we didn't know. But in the following years, there was a great deal of work done on this. And we started coming out with more guidelines within the first 10 years of that really showed us who could take this safely and who shouldn't, and what kind of estrogen should be used. And I think that's really, to show you how far we've come with all of that, is that in 2002, the group that wrote these papers came out and said, I wouldn't use estrogen. And in January of this year, they came out with a 20-year follow-up and said, estrogen's a great alternative. And so, it's a tremendous flip-flop. So really now things like, you're going to get breast cancer like you're concerned. All these things are misinformation now, that they're wrong. And so what we're trying to do is re-educate people. But I'll tell you what's hard for us is that if you're told something like you were when you were younger, it's like, this is going to get you. If somebody comes along and says, no, you're fine with that, you're really going to struggle to just flip in your brain that everything's okay. And really, what we try and do is like you do with fascia, which is having a great moment right now. I'm reading on social media, everybody's kind of getting into that, but so is menopause. And menopause now, there's a large number of people that are really getting on social media and podcasts. And there's a tremendous amount of education going on for the public. And people are very thankful that they're learning things. There's meetings where people go for 3 days to really learn a lot about the detail of what I just talked about, just so that they can bring their minds around and kind of grasp what we're saying, so they have no fear in taking the hormones. Now, does everybody need hormones? Is that what we're saying now? No, it's not what we're saying. But we know that over 80% of people who go through the menopause, and oh, by the way, if you live long enough, it's not if you go through menopause, it's when you go through menopause. So we're talking about half the planet of people are going to go through this condition that really few people are talking about. When your children go through puberty, you can go to any pediatrician and they'll talk to you all day about all of those hormonal changes. But somehow we get to a woman when she's done with, having babies in the midlife, why isn't that important? And so there's a lot of things that happen because of this study that just make it real hard to get help right now. And are you a candidate? And is this the right thing for you? We have a pretty good understanding now. It's just educating the public to ask the right questions. And I think the biggest thing is educating doctors, young doctors, because there's just bad information. And recently on all the social medias that I follow, there's story after story after story after story of people going in and being kind of like, what's the word, dished or whatever, that people just write it off and, doctor, I have this concern and I feel terrible. And it's like, you'll be okay. And just, good doctors, people with great reputations, but they just don't know. And so they'll say, well, you'll get through this. It's like, really? 20% of women who go through the menopause will continue to flash the rest of their lives. Most women will flash 7 to 10 years. That's the average, wow. 7 years. And if that's not bad enough, another 20% of those people will flash as long as they're not treated for the rest of their life. And so just to say, well, you'll be okay, it'll be over soon. No, it won't. You don't know that. So the thing we want to really say is we understand what estrogen is, which compounds are the safest, who are good candidates for it, and the biggest thing is just convincing patients that this is a safe alternative. If they want to, you still have to say yes to it. But it is a safe, and it's bioidentical, and it's not from a compounded pharmacy. I'm concerned about the compounded pharmacy preparations. Compounded pharmacy preparations came out right after the study came out in 2001, and said, we're the alternative because we have the safe estrogen. And that was a claim you can't make a claim like that. It's like saying, well, come buy my salt. I have the safe salt, or I have the safe sugar. You can have as much as you want. So, but you just have to have a knowledge of how these compounds are used and talk to people about their desires and if they're candidates and what their desire is. And most people are candidates. That's the real hooker, is that the rule of thumb is if you're within 10 years of your last menstrual period, or you're less than 60, unless you've had a breast cancer or blood clots, you're probably a good candidate for estrogen. And it's not the rest of your life necessarily. Like I said, there are those people that if they're not on medication, they'll flash and be miserable. It's just something you talk to your doctor about, the person that knows about it. You talk to the person prescribing it every year, and you just kind of like, okay, where are we at? What do we want to do? And a lot of times what I would do is say, okay, you've been on it for 3-4 years now. Here's your prescription. Don't pick it up for 2 weeks. And if in 2 weeks you feel fine, don't get it. But if you start to like, oh, here it comes again, then go get that prescription. So does that give you some sense?
Yeah, I remember us having that conversation too about how long do you do this, right? The other thing I wanted to ask in regards to this is we're talking about estrogen a lot because that's the study that came out, right? But I actually started progesterone prior to that because that's what was showing up as low, and that actually goes way back to when I also dealt with infertility for 3 years. And so at the time I was living in Washington, D.C., and I had there was so much going on with in that time of my life. There's and there, to be talking about menopause and the information that's not available or is coming out now. Boy, talk about infertility. That's a whole nother thing, right?
Oh, yeah.
So I went through that too. But in that, on that part of my journey, I found out that, and having loved biochemistry, going into, thought I was going to do nutrition way back in the day. I love all that biochemical pathway stuff. I found out that progesterone, like when you're super stressed, there's one step in that biochemical process that will take progesterone and turn it into cortisol. So when you've exhausted your adrenals and your cortisol is low, right? Now you're going to steal from your progesterone. No wonder I was like all kinds of stress in my life. So taking progesterone wasn't a new thing for me. I had to take it for a while, years before.
Right.
So then you started me on that, and I felt so much better. And let's talk a little bit about this whole symptom-driven thing. So if someone comes in and they're talking to their doctor about this, I think sometimes there are symptoms that people are experiencing that they might not know that, oh, this could be a hormone thing.
Yes.
So what kind of symptoms do you see? And then how does the progesterone, how do you determine, and then the testosterone piece and all those.
But there's a
pieces.
long list of symptoms. And the reason is, and people talk about these hormones being the sex hormones. And people are getting away from that term now because you relate it to the sex, female, or having sex, but it's so much more than that, because the way these hormones work is they'll go to a cell in your body where we call it a receptor, and that molecule of estrogen attaches to the receptor and causes change in that cell. Those receptors are everywhere. And I think there's a crazy, over 200 receptors in the body for estrogen. And for instance, I've had patients that just had aches in their joints and muscles, and not as much, hot flashes. And I've seen people go to orthopedic doctors, rheumatologists, right? And really, what's going on is estrogen. A lot of people get a lot of aches and pains because of the absence of estrogen. And so, in fact, the new name for that issue now is the musculoskeletal syndrome of menopause. They've even given it a name. So it's important because now it's got a name. But and there's just so many places where people will get symptoms. I think the biggest one that's complained about is mood. And people just don't feel like themselves. Sometimes I would get somebody come in and say, my family is about to put me out. You gotta change things. I remember, I'll never forget this. I had a woman that came in, and she was very jovial, and all of a sudden she closed the door and sat down. She goes, "You have to help me. I am the CEO of a large company, and I can't think my way out of a paper bag. Do something." And it's like, okay. So, but there's just this an array of issues. And a lot of times people will come in with symptoms, and I'll just say, give me 1 month on estrogen, and if this doesn't work, let's move on. But you're right at that time of life where this might be very real. You might not have the traditional symptoms like hot flashes. And a lot of women don't. A lot of people come in at that time and say, yeah, I've got flashes, but they don't wake me up. They're not really giving me a hard time. And, I don't want to do anything. It's awesome. And so, but so many, what we're after are the people with so many symptoms, and that they have loss of quality of life. There's an interesting article put out by a European journal recently, that really caused a great stir to the researchers here in America, because they talked about menopause and the way to treat it. But the way they approached it was that they commented that there was an over medicalization of the menopause, and just, doctors were making menopause a disease, but it's not a disease. It's just it's a transition in life, and it is a transition. It's not a disease. It's not a state where you have to, give something back, because it's a transition. And for a lot of people, they don't have those issues with the transition, but a lot of people do. And in 2002, almost 50%, 40 to 50% of the women in America going through this transition were on hormones. Today, about 40% of the people in Europe, especially England, are on hormones. But in America today, 4% of women are taking hormones for this issue.
Wow.
So it's hardly an over-medicalization of this. And why is it so low? It's because people are scared, because people don't understand, because people just have been told, like you said to me earlier, my mother, oh my gosh, my mother had cancer. And it's like, there is no scientific evidence that would relate a family history to your specific increase in risk of getting cancer just because you're on hormone. Now, you will have an increased risk because of family history, but not because of being on hormone. So it's just, nobody knows and understands these nuances of how this stuff really works for people. And it really takes, it takes some time to sit down and go through this and get a good medical history from people, because it changes lives. And, I let you speak to that. If you're one of those that I don't feel good, and you take it and it's righteous, you feel great again, then, we should be interested in finding those people, educating those people, and getting them on something that is really helpful. So
yeah, I will just chime in a little bit more about this whole symptom thing. So I think it's very interesting that you're talking about joint pain, because of course I see a lot of that, right? And so this comes up on so many levels. But for myself, I wish I had journaled about it all back then. But in a few days, I was able to sleep longer. I've been going on like that maybe a month, and the closer it got to your appointment, the worse it got. It was like I'm sleeping 20 minutes now, like all through the night. It was worse than having a newborn that would needed to be taken care of every hour, which I had that experience too. So yeah, not only did I sleep better, but then everything started working in my body better, because I was actually getting repair time again. And I remember that it was almost like a fine line where I could feel my whole body shifting. So it was just not only that piece of, okay, I'm sleeping better, but because I'm sleeping better, all of these things like the mental clarity, I was able to then exercise more. I was able to do my job better. I was able to interact with people in my life on a personal level better. The mood piece was better, all of these things. And, I think even at that point, I wasn't 100% buying the fact that this was totally okay. I trusted you, and I'm like, yes, get me out. I don't care. Like, I kind of sort of listened to that, and then in the subsequent appointments, you just kept reassuring me. I'm like, oh, this is fabulous, because I can continue to have this. Because I had also noticed my skin was better. All of these other little things.
That's a great one.
And I remember you saying, like, hey, it's like the best skincare program you can ever be on, and it's so true, because then I had to I had to pay quite a bit for my prescriptions. And I remember putting it into perspective. Okay, is this worth $100 a month? Yeah, it is worth $100 a month. So that was a big thing. But at one point, and we talked about the bioidentical, and both of these were bioidentical, but I was taking the pills initially for estrogens. I was taking a pill for progesterone. and a pill for estrogen. And I started to not feel as well with that. And you switched me to the transdermal one, remember?
Yes.
So we talked about that, and I really did notice a difference with that. And I'm assuming that's not everyone that has that problem. There's all these different types of estrogen, right? And we talk about the vaginal estrogen creams. And could you talk a little bit about the different types? And then I also want to dovetail into the whole, who is appropriate for that type, and then the vaginal cream. So.
Absolutely. The studies back in 2002 were all done with the hormone. It's called equine estrogen, and it came from horse's urine, which a lot of people have an issue with. But that's not really used all that much anymore, and that can cause a number of issues. It is interesting, though, that when that big study was done, there was two groups that they looked at. One group, women who had a uterus, would take estrogen and progesterone. And then there was a group that didn't have a uterus that just took estrogen. It was very significant, and they just put out another paper about this, a 20 years later thing, that the group that had just estrogen, not progesterone, but just estrogen, there was over a 20% less risk of getting breast cancer, number one. And number two, there was if you did get breast cancer, you had over a 40% less chance of dying from it. So, just that study alone should have arrested our attention and said, estrogen, breast cancer, how can that be when you see this study with just estrogen not showing the breast cancer? But they didn't talk about that in 2002. They just talked about the part of the study that there was more breast cancer. Anyway, but now we've come a long ways, and we've looked at the estrogen called estradiol, and you can call it a bioidentical, which, by the way, the term bioidentical is never a chemistry term. Neither one of us learned that in school, but it actually became a marketing term. But all it means is the estrogen that your ovaries made or make. And we found that it comes from the Mexican yam. And we find that if you use estradiol, that it has neutral effects on breast, number one. And also, again, like the heart attack stuff, if you start taking it right after you go through the menopause, you don't see the spike in heart disease. There's some wonderful, I think, research done on it. And so it's very positive. And so most people just use the estradiol now. And the progesterone used 20 years ago is not the same one that they use today. Today, they use the purified progesterone. And it helps. The one that they used in 2002 actually made women more emotional, which people didn't like. Yeah. But the one today is actually can help you sleep. It will actually give you, we recommend taking it at night because it can make you somnolent. So, the estradiol and the purified progesterone is really what we use today. Now, the other thing we talk about is that Cindy said was the transdermal. It just means it's through the skin is all it means. You can use it as a cream, a patch. There's one preparation you put in the vagina and it absorbs it into the body. And so we like that. Many people like that and try and get all their patients on that because one of the side effects of estradiol, even estradiol, the purified, is that you see a slightly increased risk of blood clots. Not a huge, it's less than 1 in 1,000, but it's there. It is increased. But when you use it through the skin, that basically takes that back to zero. And so that has to do with if you take a pill of estrogen, the first place it goes is your liver. And what it does is it makes all of the factors that make you clot your blood. But when you put it on your skin and it's absorbed through the skin, that doesn't happen. So you don't have the increased risk of blood clots. So for a lot of people, and a lot of doctors who are in this world of menopause, they really go for the transdermal, it's called, just through the skin is all that means. And so, we love transdermal. And it's also good, one of the best things, if you're a headache sufferer, transdermal is your choice of estrogen.
Isn't that interesting? We might not know exactly why that is. It just seems to be.
It has less effects on the blood vessels.
Again, there's so much stuff we didn't know.
I know. Like, we're learning slowly.
So let's talk about testosterone.
Oh yeah.
Yeah. So that never came up in my needs per se. I didn't have the symptoms, I suppose, that would lead to us checking into that. But we're hearing a lot more about it now because everybody's talking about, the three, the progesterone, estrogen, and testosterone. Tell us who might be at risk of having low testosterone. When would you might want to have that checked, and how that all fits into this piece?
I think the main thing is, the one symptom everybody talks about is the low libido. And everybody wants it to help their libido, more desire for sex. Low libido is somebody who wants to want, is another way I would describe low libido. And people will come in with that. And that, when people come in with that symptom, it's not always just low testosterone. When you look at that symptom, you have to break it down to not only biological reasons, but maybe psychological or psychosocial reasons. For instance, I always ask, people come in and I just don't have any drive. And one of the first questions I ask is, do you love your partner? And if people say, it's like, all the testosterone in the world won't help you. And so, you have to look at that and break that down. But a lot of people are like, no, I'm like really happy where I'm at. And, I'm not upset about anything. Life is great. But I just don't think about it or want it. But I like to want it. And so what we'll do is I don't start testing testosterone levels necessarily, but I will, sometimes I will, but I'll also check the liver because testosterone can affect the liver. And so what you do is you start them on a low dose and you just kind of build up. Women, actually the interesting thing about testosterone is if you're a premenopausal woman right now, your ovaries are working, in other words, you have more testosterone in your bloodstream than you do estrogen, which is interesting to note because the production of estrogen comes from testosterone. And so, if you're not making any estrogen, you may or may not have a normal or a low testosterone level. So you can check those levels, but what you want to do is you want to start off and you give people, women need 1/10 of the dose that men have. Like if I went to the pharmacy and I was picking up a prescription for testosterone because of symptoms, the dose they would give me, if Cindy came in, they would give her 1/10 of that. Mm-hmm. And so that's how we figure it out. Mm-hmm. And so the symptoms why I would give somebody testosterone is really libido, but also just quality of life. Man, no energy. It takes me a while to get out of bed. I get halfway through my day. Oh my God, I'm fatigued. Just things aren't interesting anymore. And so you got to look for other reasons. is there depression going on, anxiety, those things which are also common at midlife. But if people feel pretty good about that, I would trial testosterone. And again, the concern people have about testosterone is that, like I just alluded to, it turns into estrogen. And so if you give somebody testosterone alone, you're going to raise the level of estrogen in their body. And could that hurt somebody? And those are just discussions. You just get that medical history, and then you just say, okay, this is the way it works, and these are the things we could
usually,
right?
The practice of medicine.
Right. And so you trial these things, and then we're not trying to get it so women have side effects like acne, or all of a sudden they come in and they're buff. But you want to just raise the amount of testosterone up slowly, the testosterone very slowly, so people don't get the side effects of too much.
Yeah. Okay.
But it's you want to trial these things for about 3 months to see if that affects the symptoms that people are having, and give them a better sense, quality of life, I call it. And so and a lot of people come in and just say, I'm good. I'm good. And so so testosterone, it should be something that you talk about. And it's really, again, just being honest, because there's a lack of education. If you can get the estrogen from a doctor, a lot of times they'll just shy away from the testosterone because they don't understand that it's like, why would you want that? It's like, not your call. But it's just something you need to find doctors who understand this. And I would happily enter into a discussion with people about desire for testosterone.
Yeah, interesting. So talking about some of the women's health issues that I see in my patients, this whole, I see people who've had pain with intercourse,
yes,
a lot of pelvic pain. Dryness, of course, is always a part of this aging process as well. And, some come in and they've been prescribed a vaginal cream, others not. What would be some indications? So for women who are wondering, is that good for me? How is that different than maybe what I'm already taking for my estrogen, if they are taking anything, or if they're considering it, what should they inquire about? And what are some thoughts on that?
First thing I would say about vaginal estrogen is that, if you get some and you take the package insert and you look at it, it always warns against breast cancer and some of these other things that the government makes them put in their package insert. There is a lot of scientific evidence that vaginal estrogen is very, 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 very extremely unlike taking estrogen through a pill or putting it on your skin. In other words, systemic. When you take a pill, it goes all through your body. But when you use vaginal estrogen, you're putting it in one place, and that's the only place it works. If I gave you vaginal estrogen and started checking your estrogen level every day, it would never budge.
Really?
And what you want to understand is I gave a lot of vaginal estrogen to breast cancer survivors because it is totally safe. Interesting place we're going now is that I'm getting off, but
that's okay.
You'll bring me back, right?
Yeah, I will.
But one of the big places people are looking at is giving this to really elderly women in, what would you call them? We used to call them retirement homes, but you know what I'm saying. And the reason is
assisted living.
Assisted living. Thank you. That's the nice term. And because we used to, and I remember when I was in training, we'd get elderly women from these institutions that would have urinary tract infections that would put them in the intensive care because they had bacteria throughout their body. We call it sepsis. and it was from a urinary tract infection. Why would that happen to these women? It's because of vaginal dryness. In fact, the new name for vaginal dryness is, nobody wants to be told that your vagina's dry, Like, a man would never want to hear, hey, your penis is dry. But now we call it genital urinary syndrome of menopause. Genital urinary syndrome. And the reason we did that is because it's not just the vagina. It's the bladder and the whole mechanism for the bladder and urinating and all that. And so when you have that condition and you don't have that estrogen, you set that area up for getting bacteria into the bladder. And so what they're experimenting and what they've shown is that women who are treated, elderly women that don't have complaints about low libido, that's nothing to do with it. Mm-hmm. This is about reducing the risk of urinary tract infections. In fact, for a lot of people in the menopause space now, if you come in and say, I've had a urinary tract because I've had sex, or because I've just rode a bike, bike to the bay, came back, bad urinary, that is indication enough, if you're menopausal, that is indication enough to start you on vaginal estrogen. Not even because sex hurts. Mm. It's because, getting these urinary tract infections because of the dryness. Mm-hmm. So that whole world is being looked at so differently now. Wow. And it's a place where we feel really strongly that why would you let somebody suffer and have these symptoms when we can give something so safe, so safe, and it doesn't cause blood clots, doesn't cause breast cancer, like I said. It is something that just works there. And we really emphasize that you want to put not only some inside the vagina, but also you want to put it around the opening of the vagina. If you look at the vagina, excuse my hand work here, but if the vagina is an opening, this opening rim here is called the vestibule. And that's where most issues, people with pain, that's where most issues happen. And so you put estrogen on that area, and that will help greatly. And that takes me back around to the testosterone discussion. We like to give testosterone in that area too, because there are testosterone receptors in the vestibule. And if you want people to be really comfortable with intercourse and not have that vestibular pain, then we give an estrogen/testosterone combination.
Oh, that's fascinating. I love this.
Yeah.
So is there ever an indication for someone who's on HRT, hormone replacement therapy, taking estrogen already and progesterone maybe, that they would need to do the vaginal application also?
Very common.
It's very common.
Very common, because a lot of times, the amount of estrogen you need to quell your symptoms like hot flashes, it's fairly low. You got to remember, hormone therapy is less than a quarter of the dose that you see in birth control pills. So here's birth control pills, here's hormone therapy. And so a lot of times, your body doesn't need that much estrogen to take care of a lot of these symptoms, but it may not be enough for the vaginal symptoms. So commonly, people come back and say, hey, I'm sleeping, I'm great, but it's still touchy then.
Yeah.
So then you say, no problem. And you start, at least the vaginal estrogen. So and that's really a common combination of the systemic and the vaginal.
So the vaginal treatment you want to do also every day? as much as possible, or is that
No.
something that doesn't have to be every day?
Well, you do it for the first like 10, 14 days every day, and that builds things up real quick. Then you just use a maintenance dose of twice a week. That's it.
Wow.
And you don't need that much, but you need however much it takes to make you comfortable. There's not a only take this much, but it's like, well, if it's not getting there, then you use a little bit more. So
that's fascinating. Oh, such great information.
yeah, it's helpful.
So I would love to ask you, we had a few moments talking before we started recording here about how just the environment on menopause has changed. You mentioned a book also, get the name of that book and give you a chance to bring that up. But what do you think is important for women in this space to know that maybe we haven't touched on as far as the hormone replacement or any other thoughts that?
Well, there's so many books being written now by these menopause gurus, specialists, thought leaders. And the one I would direct you to is called The Menopause Brain. And it's by a Dr. Mosconi, who's a real sweet lady. She's quite Italian. And she's not a clinical doctor, but she's a neuroscientist. She studies the brain. And she got into studying female brains because she was people who are menopausal. Before the menopause, people getting dementia is like 1-to-1. For every woman having dementia, there's a man getting dementia. But once women go through the menopause, there are 2 women getting dementia to every 1 man. So that incidence really, it doubles. And so it's just like, okay, what's this about? And so she did quite a bit of study for so many years, and she wrote a book called The XX Brain. XX meaning the genetic symbol for women, and talked about dementia. And when that book came out, everybody said, this is so wonderful, but what about the menopause? What's the menopause got to do with all this? And so she went back with all the material. She had all the material she needed, and she wrote this book. And it was released in February of this year. And by March, it was on 6 different bestseller lists. Wow. And the reason is, this is a woman that says, really, menopause is a brain-ovary connection. And once the ovaries stop working, the brain is left with a whole bunch of things it has to deal with because it doesn't have that estrogen. And so you get into all these symptoms. Women feeling like they're crazy, women feeling depressed. And oh, by the way, if you want some entertainment some night, look up some of these old gynecology textbooks. I have one from the 1920s that the word hysteria was actually coined to describe women in the menopause. And hysteria came from the uterus. And so, because women going through, once the uterus stopped bleeding and all that stuff, when it stopped working, women became hysterical. And so, just entertaining the way they looked at it back then. But now we know so much about what happens to the brain. And so she gives in that book, and I think you'll like this because I've come to really think like Cindy. It's not just an estrogen thing, but she spends half the book talking about, getting out and moving, doing exercise. And what are you eating? And by the way, are you sleeping good? It talks about all these things. And like Cindy does, she brings in life and everything that you're doing. It's not just this isolated thing. And she talks about all of these things in light of what's going on and how those things actually her research has shown, like for instance, how much sleep helps the brain. And so some of these things, and now there's all sorts of, there's just a paper that just came out about people, you love this, people that do resistance training or weightlifting, what we call weightlifting, that people that lift heavy, which means just as much as you can, you don't have to lift 300 pounds, but just as much as you can for you. But women that do that have a very definitive drop in the amount of dementia that's seen. And they're just trying to learn, like, what's that have to do with anything? What caused, that to happen? So there's just some really fun and exciting things going on with the brain in menopause. So I think that one book would really help people, because really she thinks much like Cindy thinks. It's just, again, the whole person, and you can't leave any of that out. Yeah.
Everything is connected.
Everything is connected.
Everything is connected, right?
And if you don't think so, just ask her.
So, and it also ties into essential therapies, which is why I chose that name, because it's never just one thing. Like, you could get yourself talking, well, this leads to this, and well, there's this connected. I mean, as you were saying that, it even reminded me how with the women's health work that I do and the fascia, and how it can get so solidified around organs, specifically ovaries, talking about this topic. And so I had a woman once who came for intensive treatment. I saw her for like 20 hours in a week. And she had endometriosis and, was trying to get pregnant. And what happened was, when she was getting lots of ultrasounds, because she was going through all these treatments, and they could never find her ovaries with the external ultrasound. They always had to do the internal one to find her ovaries. They had to find it, right? They were adhered to the abdominal wall. So she felt so different at the end of our work together that she went to have an ultrasound that following week. Okay. So she couldn't believe it. She called me and said, I got to tell you this, because my ultrasound tech, who she actually knew, she'd been there so many times, could find my ovaries with the external wand. Like, they weren't stuck to the wall anymore, right? Well, and so one of the videos I did with John Barnes, he mentioned, every organ is in a fascial sac, and that fascia goes through the organ, right? So if that's all compressed down in a straitjacket, if your ovaries are all in a straitjacket, do you think they're producing testosterone and estrogen or anything at all very well? Are they able to release follicle, all this, So fascinating how, yes, everything is connected, and how... And
then the inflammation, all that stuff.
Everything connects. So it sounds like, even though we've come so far in 22 years since that first article you talked about where it vilified estrogen, we've come full circle from that. Maybe 180, I guess, is a better way to say it. But we're really at the beginning, because there's so much more.
Now we just have to educate people.
Right.
And not everybody, and I want to leave the big message, not everybody needs this.
Yeah.
There's a substantial number of people, it's like, good, and do really good. But for those people suffering, it's like, you don't have to. Just like, if you've got... I came to Cindy for a lot of issues, especially shoulder, I remember. And it's like, I saw Cindy because I really believed I didn't have to feel like that every day. I did not want to age, and I am retired, and wake up sore every morning. And I don't, because, I think we've worked together. So you just don't have to feel that way. And so get the essential therapies that you need.
Yeah, and research.
Yeah.
Learn.
Amen.
One thing leads to another, right?
Amen.
So thank you so much.
Oh, thanks for having me.
For having this conversation.
You bet.
And would there be a reason, or is there a place where people can reach out to you at all?
In the Toledo area, I'm sorry to say, a lot of the people doing a lot of menopause are leaving the area. There's one person whose last name is Wahl, W-A-H-L, at Flower Hospital. She's just going up to St. Joe's in Ann Arbor. She'll be there. But a great place to look is it's called the Menopause Society. It's menopause.org. And on that website, there is people who've gotten a certification that organization gives. And there's a list of them. And so you can find somebody near you.
So they've had more than just the traditional stuff.
Right.
So, yeah. And I have to say this because, you know, your ears probably are ringing here now and then because people are so sad that you've retired. I have to tell you.
I appreciate, I love hearing that, but I'm sad.
All the time, yeah. So anyway, very, very well appreciated and loved here, and looking forward to the education that you're giving to not just patients, but to clinicians, because it's very well
Very
needed,
important.
So
thanks again.
Thank you. Thanks for joining us.